Hey, happy Respiratory Care Week 2022. I'm so excited to be here. Big shout out to Respiratory Associates for inviting me back to do this year's free Respiratory Care Week lecture again. And again, another big shout out to Radiometer America. We appreciate their efforts in going forward and providing you guys with continuing education. Now, as Keith stated, this is about mechanical ventilation, but I thought maybe we could just talk about the simple mask for the next hour. And that's a joke. I'm just trying to get a laugh, which is really hard to do virtually. So, but no, Keith is exactly right. A few disclaimers here. The point of this is to talk about mechanical ventilation. And like Keith said, there's no way that everything we're going to touch on today, this is probably more like a 4 or 5 or 6 hour course. And so recognize that this is surface level, scratching the surface, but I'm hoping to scratch it to spark something inside of you that you go, oh, that's interesting. Maybe I have never thought about that like that. And then you're going to go out and deep dive into it to become a better respiratory therapist on your own. That's what it's all about, right? Now, so this is what it is, the 5 questions. Here's the objectives. We're going to discuss how to ensure adequate ventilation, how to ensure adequate oxygenation, how to protect the patient's lungs using lung productive strategies, how to identify and meet the patient's neural demand to breathe by reducing asynchronies, and then evaluate if the patient is getting better or worse. Okay, now, there's a lot of people in here, and if you just thought to yourself, oh, great, another boring presenter who's going to read a bunch of PowerPoints to me, I want you to know I did something different. I said, you know what, we're going to do it a little different this time. And that's the last slide that you will see that has text on it. From now on, it's going to be all images that spark a conversation. And this conversation is one that will hopefully intrigue you, and you're welcome to be a part of it. Now, there's too many people in here to have mics on, but feel free to add anything in the chat you would like to at any given time. And then at the end, we're going to come back and answer any questions. Now, as we know, this is an image of a mechanical ventilator. And I just want you all to know that there was a time in my early years where I was the absolute I was the fastest vent checker in the world. I literally was. You could give me 10, 12, 14, 15, you give me however many you wanted. And guess what? All the vent checks got done all on time. There was never a time when one didn't, because I could blaze through them. And I remember somebody telling me one time, like, man, you're so fast at this. Like, how do you do this so fast? And I remember thinking to myself, well, why are you so slow at it? And many years later, I've now come to recognize that that respiratory therapist was actually performing true ventilator assessments. They were not doing vent checks. And so the point here today in these 5 questions is to hopefully illustrate to you that every time you stand in front of a ventilator, there's a purpose for you being there. And that purpose is not to just simply write all those numbers down, put them in the computer. A lot of times they're already pulled over anyways, and we just duplicate them, right? And so 5 questions to make you a better respiratory therapist, to improve outcomes and move beyond vent checkers to more patient ventilator assessors. So this is, as we know, mechanical ventilator. Now, we know when we talk about mechanical ventilation that there's always hazards involved. As with everything that we do, right? But mechanical ventilation comes with some hazards. Now, what I think is very interesting is I was putting this presentation together, I recognize that if you'll ask yourself these 5 questions, then you'll also be observing and monitoring and keeping an eye out for your patient by avoiding just about every hazard that comes with mechanical ventilation. These questions address the hazards that come with mechanical ventilation. So without any further ado, let's jump into the first question here. I tried to change my slide on the computer. So question number 1 is, and I'm going to talk in first person here. Okay. So am I adequately ventilating my patient? Now, when we say ventilating, we understand that we're talking about the removal of CO2. This is CO2 control, or the elimination of carbon dioxide. We know that as respiratory therapists. Now, remember, I told you there's hazards with mechanical ventilation. So by asking yourself this question, you should address 2 of the common hazards that happen. One hazard being hypoventilation, the other one being hyperventilation. Both of those things can happen during mechanical ventilation. And so we recognize that when we adequately assess carbon dioxide levels and the appropriate removal of it, then we eliminate those hazards, right? Now, here's the kicker though. The kicker is that we can't just look just at CO2. You can't just get a blood gas and just go, oh, this person's CO2 is 40, we're ventilating perfectly. Well, that's not true, because when you look at your pH, you will see that perhaps you're taking care of a COPDer who lives at a CO2 of 60. And that CO2 of 40 is actually equating and creating a pH of 7.54. See, now you've got your patient in a state of alkalosis. Well, that's not good. And if we want to go, remember, I'm going to have a hard time keeping this surface level, but I can get into one of Keith's favorite topics here and go, yeah, that state of alkalosis causes more problems than what we recognize, because that causes a left shift to the oxyhemoglobin association curve. That hemoglobin holds on to that oxygen tighter, and now our tissues are going, wait, where's my oxygen, right? So we recognize that alkalosis during mechanical ventilation is something that is just as important than when we get that blood gas that shows a CO2 of 60 and a pH of 7.20. We're pretty good at fixing that routinely when it shows up. You get that high CO2 and you pretty quickly go find the care team or the physician, or you make a change and then call the care team and say, hey, you know, we did this because the CO2 was high. We got to get it down. Patient's acidotic. Don't sleep on the alkalotic side of things. It's just hyperventilation comes with just as many negative effects as hypoventilation does. Now, we talk a lot about blood gases when we're talking about adequate removal of CO2, but I think there is a huge opportunity for respiratory therapists everywhere to start to incorporate and better use things like end-tidal CO2, volumetric capnography, even transcutaneous CO2 monitoring, specifically in the neonatal and pediatric populations. You see, those are non-invasive markers, non-invasive tools that we can utilize to help us better monitor our ventilation of our patients. Now, before you get at me here and say, wait a second, Joe, like, here's why we don't use CO2, end-tidal CO2 more often. Because it never matches the CO2 in the blood gas. And I'm here to tell you, or to remind you, it's not supposed to match. You recognize that end-tidal CO2 is a trending tool, so that when your arterial CO2 goes up, your end-tidal follows it. So you don't need a blood gas to know that your CO2 is higher when you have an end-tidal CO2 that is showing you that it is elevating. Same thing when arterial CO2 goes down, end-tidal CO2 will go down. You don't need a blood gas to recognize that. Think about how valuable this could be during a spontaneous breathing trial. I don't know if the patient's ventilating well or not. We don't have to guess. We have these tools. We just have to utilize them, right? And so keep that in mind when you're thinking about how can I assess CO2 removal of my patients. I also just had a conversation last week with a physician out of Denver, and this physician was telling me that they don't even utilize arterial blood gases. They manage their mechanical ventilated patients from a CO2 perspective with venous blood gases. So think about the arterial sticks. How many times are we sticking our patients for an arterial blood gas when a venous blood gas in relationship to pH and CO2 is valuable? And there's studies out there, research that shows that that's a way to do that. That's question number one. Am I adequately ventilating my patient? Keep that in mind when you stand there. Now, question number two, am I adequately oxygenating my patient? So we get CO2 out and we get oxygen in, two hazards. When we put somebody on mechanical ventilation, we can cause hypoxemia. If we don't adequately provide them with the FiO2 and the PEEP needed to adequately oxygenate them, then that can be a hazard. Now, here's interesting enough is this. The other hazard is oxygen toxicity, formerly known as oxygen toxicity. And now we call it hyperoxic acute lung injury. See, hyperoxemia comes with just as many dangers as hypoxemia does, even so much to the point that there was a study done and it showed that states of hyperoxemia, PaO2 is greater than 100 for the first 48 hours from ER to ICU equated to a higher mortality than hypoxemia. Interesting, right? So how do we monitor our oxygen? Well, this is easy, right? Everybody knows this. This is, oh, he's going to show us a picture of the pulse oximeter, and that's exactly what I did. And I just put this up here because I thought it was so cute. And we monitor there also. This also is interesting to me because I put the little neonate on here. You know, we're so good at titrating oxygen in the neonatal world, right? We know that retinopathy of prematurity is a hazard. And so you walk into a neonatal unit and it's very common to see saturations of 85, 86, 88%. Rarely do you ever see 100%. And yet when I walk into the adult ICU realm, I see patients all the time, 100%, 100%, one patient after patient after patient, 100%. Now, the reason I'm bringing this up is because we need to understand what is adequate oxygenation. We know that a normal PaO2 is 80 to 100 millimeters of mercury. We also know that data supports the fact that PaO2's 55 to 80, especially in the ARDS population, is what we should be targeting. Now, so what you recognize here is that 80 number seems to be the low end of normal and the high end of an adequate target during mechanical ventilation. So let's ask ourselves, how do I know if my patient has a PaO2 of about 80? Well, that turns out to be a saturation of about 96%. So what about targeting that? What about targeting for shooting for 55 to 80? What about targeting 88 to 95%? Right? See, so my point is that we are utilizing our non-invasive tools to not just prevent dangerous hypoxemic levels, but also diligently wean FiO2s aggressively to prevent hyperoxemia and to prevent these states of hyperoxic acute lung injury. You know, I did a little some research into hyperoxic acute lung injury. And it was very interesting to me what I found, because when you start looking at chest x-rays associated with hyperoxic acute lung injury, you find that they look almost identical to an ARDS chest x-ray. And I start asking myself these questions going back through the years and years and years of how many times we had patients on high FiO2s for way too long. And I start asking myself, how many of these ARDS patients have I taken care of that were the result of me not diligently providing adequate oxygenation, not excessive. So it's interesting stuff there that, I don't know, I get lost sometimes thinking about it. But remember, we want to ask ourselves, are we adequately oxygenating our patient and wean FiO2s appropriately to achieve that adequate oxygenation? Now, the third question is that you should be asking yourself. The first two are pretty simple, right? Like everybody knows that, okay, am I ventilating? Am I oxygenating my patients? Pretty clear, cut and dry, right? The next one is am I protecting my patient's lungs? Now, when we talk about protection, there's several different types of traumas that can occur during mechanical ventilation. So let's just look at them here. This is an image, and you can see here, this person here has, well, I didn't mean to do that. This person has some injury over here to the right lower lobe. This is an example of a pneumothorax resulting from barotrauma. Barotrauma. Now, what is barotrauma? Barotrauma is the results of excessively high alveolar pressures during mechanical ventilation. Makes sense. We know this. We learned this back in school. What's one of the hazards, two biggest hazards of mechanical ventilation, right? Barotrauma and decreased venous return, which, interesting enough, isn't even in this conversation today. But barotrauma is. So we want to make sure that we are monitoring our pressures. Now, how do we do this? Okay, so how, when I'm at the bedside, how am I thinking about how can I prevent barotrauma for my patient? Well, the ARDSNet protocol told us 20 years ago that plateau pressure is the indicator, right? 20 years ago, it said, hey, plateau pressure less than 30 centimeters of water pressure, use appropriate size tidal volumes, 6 to 8 mLs per kilogram to prevent barotrauma and utilize this new method of mechanical ventilation. But you know, what's funny is in 2015, roughly 7 years ago, they came back and said, you know what, maybe it's not plateau pressure. As a matter of fact, maybe it's this theory called driving pressure. You see, driving pressure is plateau minus peak. So we say, okay, well, where do we want to keep that? Well, research varies, but roughly you see some that state less than 15, less than 14. The lower, the better. That's the point with driving pressure. Is if you have a driving pressure of 20, even if your plateaus are less than 30, that is associated with worsening mortality rates. So we recognize that we have this tool that we can utilize. The question is do we document it? Is it documented? I want you to put in the chat right now, if you will. If you document on your flow sheet, when you're writing all these numbers down, is driving pressure one of the ones you document? I'd be curious to see where that's happening. And if it's not, then somebody send an email as soon as we get done here and say, yes, hey, how do we get this on our flow sheet? Because it has value. Look at this, no, more no's than yeses. And we've got to start demanding this type of stuff. We've got to start asking about it and thinking about it. Now, you want to go one step further, we can talk about mechanical power. Mechanical power is another super big tool associated to reducing ventilator-induced lung injury. Super complicated formula, so complicated that they said, you know what? Nobody's going to do that at the bedside. Nobody's going to do this formula at the bedside. So they've simplified it. They've actually come up with a simplified version of mechanical power that shows typical similar results. And that is where you take driving pressure. Here we go again with driving pressure, right? I'm telling you, it's the future. We've got to start talking more about driving pressure. Driving pressure times 4 plus your respiratory rate, even a bigger indicator of outcomes associated with mechanical ventilation. Excuse me, talking a lot here. So that's barotrauma. Okay, so keep that in mind. Let's talk more about driving pressure. This one here, cute little girl here holding some balloons. And what comes to mind when I see this is volume trauma. You see, we recognize, and we're real good at when our patients say, when we go in and we see those plateau pressures getting too high, we're real good at going, you know what? We need to change that. We need to go over to pressure control. So we go to pressure control because now we can control our pressures and we can control our driving pressure. And then now we give volumes that are too big. Well, our pressures are good, so we're not causing barotrauma. Yeah, but guess what? There's also this concept of giving too large of volumes is equally as dangerous, not just associated with pressure. So we know that the RSNet said 6 to 8 mLs per kilogram. A lot of studies coming out now targeting more to 6 mLs per kilogram, not even going to 7 or 8. But my biggest point in all of this is I want to encourage us to think specifically about this, recognizing that 6 mLs per kilogram may not be best for everybody. Like what? Let's think about this. What if we got so creative that you had a patient who wanted 5.8 mLs per kilogram, 6.4? So we recognize we get in this box where I always use the same numbers, right? 6, 6, 6. If it's PEEP, it's 5, 8, 10, 12. That's all it is, right? We got to think about how to personalize this to our patients. When they're in spontaneous modes, are we giving them too much pressure support? What about go back to COVID when you had all these patients on BiPAP, they're just chugging away with these ginormous tidal volumes. What was happening? Outcomes weren't good. Good chance that it was related to volume trauma. It's dangerous, it's there. So keep that in mind, appropriate tidal volume size for each of your patients. Now, I had to get a little creative with this one because it was hard to find an image that could show atalic trauma. Now, when we talk about atalic trauma, we're talking about the closing and the reopening of alveoli excessively. See, we don't want that to happen. We want the air to go in our patients' alveoli and out, but we don't want this constant opening and shutting, opening and shutting. See, that's also is equally as dangerous. So how do we get better at avoiding atalic trauma? Well, the answer to that is the better use of finding optimal PEEP early in the game. See, I got a comment here that says PEEP it up. That's exactly right. PEEP it up. We got to use PEEP, but we have to find it early. You know, we sit around and wait till our PF ratio is 110 and then go, oh, we need more PEEP, we need more PEEP. Well, wait a second, let's just stop here. As soon as that person goes onto mechanical ventilation, what if optimal PEEP maneuvers were performed to find out what their optimal PEEP is, instead of trying to open up de-recruited lungs and non-compliant lungs? Just a thought. So optimal PEEP is one element. Recruitment maneuvers, a lot of data supporting recruitment maneuvers. Now, there's no superior one that says this is the best recruitment maneuver, but there are lots of mechanisms out there talking about recruitment maneuvers. There's also the use of esophageal pressure monitoring that shows that we can illustrate when pressures are excessive by utilizing esophageal monitoring devices. And then my favorite really cool technology that hasn't really made it to my area yet, but it's called EIT. This is electrical impedance tomography. And this is actually gives us a beneath the chest wall view of recruited alveoli. What sections are open, which ones are closed. It's kind of looks similar like to a CAT scan, but the imaging is different. You can actually sit there in real time and adjust your PEEP and adjust your settings and see the effects that you were getting on your alveoli. You know, how many times we increase PEEP and we ask ourselves, oh, we're increasing PEEP, perfect, we're recruiting now. Maybe we're just overstretching the healthy lung that's already there. EIT helps us with this. And there is a great, Keith, you're exactly right. That's a great YouTube channel right there, EIT guided APRV. Phenomenal technology that I hope is soon to be adopted everywhere here in neuro. So that's outlet trauma. Now this last one here is biotrauma. And this one I think is the most interesting to me, because you know what we recognize is that when we put somebody on mechanical ventilation, we are implementing a process that does not mimic normal natural breathing. We are not positive pressure breathing into humans. We breathe off of negative pressure. So the second we start applying positive pressure to our patient's lungs, especially if we're not doing it in a safe manner, avoiding barotrauma, volume trauma, and adduct trauma, then we are starting this inflammatory cascade, this cascade of inflammatory mediators, the release of cytokines that go throughout the body. And this is the beginning of multi-system organ failure from biotrauma. So we have to be aware of that. We have to be thinking about this. How long has the patient been on? Are there strategies we could use to not have to ventilate this patient or to mechanically ventilate this patient? I'd be really curious to see. I feel like we're on the cusp of, and I don't have any research to back this up, but I feel like negative pressure ventilation is on the verge of making a comeback. We now have Airvo and Vapotherm and other oxygen devices that can provide adequate oxygenation to our patients. In conjunction with a negative pressure non-invasive ventilator, I think it would have, I don't know, I'd be curious to see what the outcomes are. And if you're doing that, leave it, put it in the chat for me so you can tell me about it, because I have talked to one individual who said, yes, we were using this during COVID and they actually had pretty good results with it. So it's interesting. We got to get our people back to breathing negative pressure ventilation like we were meant to, right? And when we have to go on positive pressure, recognize that this inflammatory process is at play and we need to take all efforts to reduce it. Okay, that's our 3 questions. We've got 2 more, right? So our 4th question is, am I satisfying my patient's neural drive to breathe? This is my favorite picture in the whole slide. Halloween right around the corner. And this is what in my mind, when I see these patients on mechanical ventilation, receiving mechanical ventilation, and they're just fighting and they're so asynchronous. This is what I feel like is happening in their head. I feel like if they could, this is exactly what they would do. And what do we do? What do we do, right? We say, let's give more sedation. And all it does is take it to this fogginess of still a state of confusion and a state of my neural drive may still not be satisfied. So how do we assess our patients for adequacy of meeting their neural drive to breathe? Well, the first things first, just like I talked about driving pressure, in the chat board, in the chat right now, how many of you routinely monitor occlusion pressure? This is the P100. Go ahead and put it in there. How many of you monitor it routinely and document it routinely? You see, you got to understand that the P100 is your tool to assess your patient's neural drive to breathe. The P100 tells you how hard the diaphragm contracts in the first 100 milliseconds. And that's directly linked to the electrical impulse sent from the neural drive to breathe. The stronger the contraction, the stronger the neural drive. Now, what's happening here is you have a patient who we've said, hey, you need help breathing, and we're going to be the one to help you with it. And so we put them on mechanical ventilation. But then don't tell me we don't do it. Don't tell me we don't satisfy them. And I like that comment right there. We do it as a part of weaning, but not routinely. See, it's very common in the weaning world. But my question is why is it not common throughout the entire process? Why is it not the first question we ask ourselves when we go to take care of a patient and stand in front of them? What if we said, you know what? My first priority is make you comfortable. And instead of putting you on this ventilator and telling you, hey, guess what? I know you're not going to like this, but you have to breathe like this machine now. What if we said, you know what? I'm the expert here, and I'm going to figure out how to make this machine breathe like you. And that satisfies the patient's neural drive to breathe. Now, this shows up in a lot of different places also. So let's say, okay, P100 is cool, Joe, but take it out of the equation. Fine. You don't really need it because you can assess neural drive to breathe also by looking and monitoring waveforms and loops. And what you'll find is various types of asynchronies. So they range from anything from trigger asynchronies. And you think about it, you say, well, what do you mean trigger? Well, remember, trigger is what starts the mechanical breath. Okay, so there are missed triggering asynchronies where the patient tries to take a breath, but the ventilator doesn't recognize it. And you may think to yourself like, oh, I've never seen that. Well, I'll be honest with you, I thought the same thing until I started looking into it more, and I realized, you know what? I'm missing this more than I think I am. Seriously, like, and a big portion of it is auto peep. Auto peep, number one cause of mistriggering. It's not the sensitivity setting that's the cause. We're all really good at that. We know what sensitivity to put our patient on. But it's the auto peep that is present, right? That masks those efforts and we miss it, okay? And while I'm talking about sensitivity here for just a second, and I'm talking about neural drive to breathe, if you have an asynchrony present, like let's say the patient is double triggering. Let's say they're triggering at the end of the breath, and now they're stacking their breaths, right? And you say, you know what? I'm going to fix this. I'm just going to take my sensitivity way down so the patient can't trigger a breath. And it fixes the ventilator 100%. I don't disagree with that, right? Your ventilator gets very quiet and things get very, very good. But what's happening up here? The patient is still trying to take a breath. They're still trying to, and now they can't even get it. And so just making it to where the patient can't take a breath is never the answer to fixing asynchronies. The answer is figuring out which asynchrony is present. If it's mistriggering due to auto peep, fix the auto peep, right? If it's a cycling asynchrony, so we know cycle is what ends inspiration. So sometimes the ventilator ends too fast and the patient is still trying to take a breath. And you say, okay, well, what happens there? Well, then that's where that double trigger happens. You get another breath immediately on top of it. Now, instead of giving 6 mLs per kilogram, now we're giving 12 because the ventilator stopped too soon, cycled off too soon. Well, what about this? What about when the ventilator cycle lasts longer, right? So now you say, okay, well, now the patient is trying to exhale and the breath is still happening. Maybe you're in PRVC with this 1-to-1 ratio or pressure control or whatever it is. With this 1-to-1 ratio, and the patient's trying to exhale in the middle of it, or even a volume control with a slow flow or whatever it might be. You see that rise at the end of the pressure loop or that S shape on your pressure volume loop, and you go, wait a second, that's the patient's diaphragm actively moving in the middle of a breath. And that's an asynchrony. We got to figure it out. How can we match the ventilator to the patient? There's also flow starvation. Patients get flow hungry. So we got to make sure we're giving the breath to their desired level. And I think about it like this. I think about it like this. When my patient becomes neurally distressed, what I understand is that it's like if I was to go out and run a mile right now. Okay, I haven't ran in years. Nothing's chased me lately, so I haven't ran in a long time. I would struggle to run a mile. At the end of it, I'd be extremely, extremely dyspneic. Now, if I stopped, I could go in the tripod position and I could catch my breath, and my shortness of breath, my dyspnea would improve. Okay, that's the same. That's what we're talking about here, neural drive. At the end of that mile, I'm going to have an increased neural drive because I'm going to be winded. I'm going to be dyspneic. So if I was to keep running, or if I was to finish that mile and somebody said, hey, why don't you, now that you're done running that mile, go get on this bicycle and ride this bicycle for 10 miles, or go swim, or go get on a treadmill. If I had to keep going and I didn't have time to be satisfied neurally, then I would just stay short of breath, and I would get more and more and more short of breath. Same thing with your patients. They're going to fight more and more and more the longer they're not neurally satisfied. And so by recognizing that they want a breath faster, maybe they're volume starved and they want just a little bit more volume. By recognizing that, all we have to do is help them catch their breath, and then hopefully this will settle down. But they just need some help catching it. They may not have to stay like that. They may not need that extra flow forever, just enough to help them catch their breath, to go, thank you. I was dying over here. Literally, probably what it feels like. So keep that in mind. Are we satisfying our patients' neural drive to breathe? P100 is extremely valuable, along with your waveforms. Last question. We've gone through 4 of them, and here's the last one, and it's simply this. Is your patient progressing, or are they regressing? Are they getting better, or are they getting worse? Now, this is something that if you have done the previous 4 adequately, then you're going to know the answer to this. Also, if you're doing your due diligence, as I know you are, in getting your data and looking at your chart before you ever step in that room, and you're looking at your latest chest x-ray, your most recent chest x-ray, and if there's not one and we're wondering what's going on, then perhaps we need another one. What about our daily ABG, right? Our daily PF ratio, our RAS score, Richmond Agitation Sedation Scale. I didn't even put that in there with the neural drive, but it goes with that also, right? We think of that as a nursing thing. Like, wait, we don't, who calculates RAS score? Put it in the chat. Who documents RAS score as an RT, right? So, but why not? Why do we not sit there at the bedside and go, you know what, we should check our patient's RAS score to see how do we want to wean them if they're snowed, right? So we recognize that those are all elements that can help with this. Neuro assessments, spontaneous breathing trials with sedation vacations. Now, we're all spontaneous breathing trial experts here. I get that. But here's the kicker. The kicker is the question is not, am I going to do a spontaneous breathing trial on this patient today? The question is what reason do I have not to do one on this patient? Why am I not going to do it? Instead of talking ourselves into doing it, to say, I think we need to do it, or waiting for someone to tell us, I think the question is, why would you not? Because through the weaning parameters and through that entire process, you're going to have a much clearer picture of if your patient is improving or not, and if they're getting closer to liberation from mechanical ventilation. So all of this stuff plays in together to this big picture of, is your patient getting better or worse? And then, of course, all of these questions, because honestly, if I was to come on here before I went through any of this, if I said, what's the number one question you ask yourself? What's the number one reason? What's the number one question you ask yourself as soon as you intubate somebody? What's the first question that comes to mind? And the common answer is can we extubate them? And that's a wonderful question, because see what that does is it gets us to a state to where we're getting aggressive. We intubate them. Now, when can we extubate them, right? You know, you hear these situations. Sometimes you come in and you say, you think we can extubate this patient? We're going to try to wean this person today? They said, no, it just got intubated 8 hours ago. Okay, cool. We're going to try to extubate this patient today? Seriously, like, think about that, right? The big question is, how do we get our patients off mechanical ventilation as fast as possible? And the answer is in these 5 right here. That's the big question. But these 5, every time you step in front of mechanical ventilator, you should be asking yourself this. This is the goal we're looking for, right? We want our patients to be liberated from mechanical ventilation. We want to see these smiling faces. We want to see our patients return to whatever their new state of normalcy is. Maybe it's getting better and going back to their family. Maybe it's life transition, right? And we want that to be done. We want that peacefully. Whatever it is, this is the state we are trying to get back to and get our patients off mechanical ventilation. Now, this is my summary for you. We've talked about 5 questions, and I just want to recap them here for you real quick. Question number 1, am I ventilating my patient adequately? Am I adequately oxygenating my patient? Am I protecting my patient's lungs? Am I satisfying their neural drive to breathe? And the last question is, are they getting better or worse? And what do I need to do to continue the improvement or try to stop the regression? That's it. 2 big thumbs up to you, because I'm so proud of you. And I know this picture on the screen right here shows a lot of smiley faces and a lot of positivity. And that's what I always try to put out, is I want to encourage you to go out and be the very, very best respiratory therapist you can be. Not just for yourself, but for your colleagues, for your people coming behind you, for the new students coming in behind you, somebody to look up to, but most importantly, for the patients that we take care of, for the outcomes that we impact. And so, you know, I just want to share that and be that voice of positivity and encouragement to you. But I also understand that it hasn't been easy lately. And I think one of the things we could do right now that would maybe be the most beneficial thing of the entire day and maybe of the entire week is, you know, we don't get told thank you enough. And so maybe you and me could pick our phones up and send a text to a fellow respiratory therapist and say, I like working with you. I appreciate you so much. And pick each other up and carry forward and really truly tap into the potential that respiratory therapy possesses, because we've barely scratched the surface, just like this presentation. All right, I've got some references here, textbooks, different articles. If you'd like those, send me a message. This is where you can find me. I'm on all the socials, at Instagram, at TikTok, Twitter at CoachRRT, respiratorycoach@gmail.com. You can send me a text if you're interested. This is 817-968-7035. This is a texting platform. It is not a phone conversation, so don't call it. But it will be me and you one-on-one in a text type environment. And then don't forget my YouTube channel. You can also find that at Respiratory Coach. I thank you so much for being here, all 405 of you. Respiratory Associates, you guys rock. Radiometer America, thanks again for the sponsor. You guys rock as well.